for giving us this special privilege today to actually host the weekly clinical meeting of CPAN. We are indeed grateful. We, the Clinical Oncology Pharmacists of Nigeria, we are grateful for this rare privilege opportunity given to us tonight. And today, we are going to be discussing a very, very crucial and trending issue. It's actually the theme for this year's World Cancer Day. It's a 3-year campaign, actually. And that's why we tailored the topic of today to be closing the cancer care gap through clinical pharmacists in Nigeria. And the Clinical Oncology Pharmacists of Nigeria is actually one of the specialty groups of CPAN. And we thank God so far for His grace. He has been leading us, and we actually had our inaugural clinical meeting on July the 28th last year, and God's grace had 4 clinical meetings so far. And hello, am I still audible?
No, okay. Please, Dr. Bello, do you think we should mute everyone and disable them?
I think we should mute everyone so that only the speaker and the co-host will remain unmuted.
Okay, let me mute all now. Okay, Dr. Rita, you need to unmute yourself again to start talking.
Okay, am I still audible now?
Yes, you can go ahead.
Okay, so as I was saying, we usually have our monthly clinical meeting on the last Thursday of every month. And so far we've had 4 clinical meetings, that's last year. And then the inaugural one, as I was saying, was on the July the 28th last year. And it was actually an intro to oncology pharmacy in Nigeria, as it were. And the activities has been running very smoothly. Also, despite we are really young and we are trying to we are in the formative stage, as it were, we're able to lean our voice together with the global community in this year's World Cancer Day. We're able to create on our own 2 posters to actually lean our own voice community, talking about the cancer care gap, whereby we are saying that as clinical pharmacists, there's a whole lot we can do, even in advocacy, even in drug therapy management, to bring about better patient outcome. We are saying that the social determinants of health too, as clinical pharmacists, we can go a long way to actually bring about closing the cancer care gap, as it were. Then, yeah, they say screening saves lives. We also did a poster that actually were able to bring out the major cancers is predominant in the world as well as in Nigeria, telling people the need for them to get screened on time. Early diagnosis, they say, saves lives. Yes, even in as much as clinical pharmacists, we want our patients, those already diagnosed, to get better. But the world really is tending towards preventive means. You know, if it's any adverse reactions as a two-year. So that's why tonight we actually deem it fit as a group to tailor our talk for this night on gap through clinical pharmacists in Nigeria. And it is our honor tonight. We have one of our amiable pharmacists. He's a pharmacist of great repute in the person of Dr. Ahmed Aminu Biambo. He actually has so many credits to himself. Actually, he has done peer-reviewed journals a lot. He's actually a lecturer with special passion for oncology. And he's actually our education committee chairperson. It's our honor tonight to have him deliver today's presentation. Dr. Aminu, please, you may have the floor. Thank you.
All right. I hope I'm audible enough. Thank you very much for that concise introduction. Let me confirm, is Dr. Leila around? Not yet. Okay, since I have the floor. Good evening, everyone. The CPAN National Chairman, my desk officer, Dr. Rita, members of the Education Committee of CPAN and Clinical Oncology Pharmacists, and all other protocols duly and adequately observed. Please, can you all see my screen?
Yes, we can.
All right. So it's my privilege and honor to make this brief presentation on behalf of the Clinical Oncology Pharmacists of Nigeria to this weekly clinical meeting of the CPAN. The topic is closing the cancer care gap through clinical pharmacists in Nigeria. And I'm presenting on behalf of my specialty group, that is Clinical Oncology Pharmacists of Nigeria, on this beautiful and memorable day. I like starting my presentations with expectations. As a student of knowledge, you have to tell people that these are the things you expect, so that at the end of the day, I may be judged on whether the expectations were met or not. But from my own angle, please don't expect too much. This is a presentation, specialty group presentation coming to CPAN National. So don't expect too much oncology detail. When we go back to our weekly meeting, then we'll discuss all the details related to oncology. Okay, then you expect me to discuss on something that we already know, but at least to awaken our minds on this particular subject matter. I like my presentations to be short as much as possible. So I will prefer that this presentation takes 30 to 40 minutes. So the moderators, please, whenever it is 30 minutes, please, you can alert me so that we can quickly finish this meeting. Because educationists, studies have shown that when you talk to adults for the first 10 to 15 minutes, you will lose their focus. So I don't want to lose anybody's attention. Please, if you can give me your attention, you can borrow me your attention. Within this duration, we hope to finish this particular presentation so that we can have more time for discussion, which is actually more important for presentations like this, because sharing the experience is more important than listening. So let's say that I'm just going to set the ball rolling while we do the main to increase our knowledge and share our experiences. Objectives, of course, in this presentation, at the end of it, I would want to see that everyone appreciate the public health importance of cancer, to understand the gaps in cancer care in Nigeria, to appreciate the role of clinical pharmacists in closing the oncology care gap, to understand the potential impact of clinical pharmacists in closing the cancer care gaps in Nigeria, and to discuss the roadmaps for closing the care gap. This is a lot. Each of these specific objectives can make a presentation, which is to go back to my initial point that we will want to make everything concise and straight to the point so that we'll have more time for discussion. By way of introduction, of course, we don't have to go back to what cancer is, but let me ask this. From the topic, closing oncology care gaps through clinical pharmacists in Nigeria, if I just say that, how do we close oncology care gap through clinical pharmacists in Nigeria? If I just say that we do that by provision of pharmaceutical care and participating in a comprehensive oncology care team. With this statement, I believe the message has been sent, and we could say that the presentation is probably over. So with this, you already know my bus stop. Provide pharmaceutical care or provide direct patient care, or do this or do that. But we can go to some specifics and see. Let us appreciate the global impact of cancer. As of, I think 2020, the Global Cancer Research Report shows that there are 19 million new cases and 9.9 million deaths. So with this, we cannot overemphasize the public health impact or importance of cancer. And that means there is need for a comprehensive care, maximizing patients' therapeutic benefit and the rest. So with that brief statistics, if we don't want to be having 19.3 million cases or be suffering 9.9 million deaths annually from cancer, then there is need for comprehensive cancer care. Now, how does that look like? Comprehensive cancer care is multidisciplinary and collaborative in nature. It's multidisciplinary and collaborative in nature. If you look at this cycle, you have the patient at the center, then you have the caregivers. Who are the caregivers? There are many. You have specialist providers, physician assistants, nurses, practitioners that are advanced practitioners, clinical pharmacists are also advanced practitioners. You have advanced degree nurses, you have oncology nurses, hematologists, oncologists, primary care providers. In all these ones, the aim is to collaborate, provide leadership, communicate between the care providers, provide support to the patient and also to different care providers, have education, networking, okay, mentoring, training. All these ones are integrated in this multidisciplinary and collaborative care that will lead to that comprehensive care. Also, some of these activities, you have a lot of human factors, do clinical trial, okay, you have quality improvement, health system factors, innovations, socioeconomic factors, e-health technology. So there are a lot of things around this multidisciplinary and collaborative nature. So in this cycle, we can pick the essence is that we understand that, or we should remember that at the center of that patient, you have different practitioners doing a lot of things to achieve a lot of things. Similarly, you have this chart that shows the role of each care provider in providing a comprehensive oncology care. But what are the gaps in this oncology care? In oncology care, there are multidimensional care gaps. Yes, you could see it. Don't expect that this little discussion will address or will spell out every care gap that is in oncology. It is not possible. For instance, let us look at it. We know, of course, that in oncology, we have gap in oncology practitioners' workforce. The clinical, even among the physicians, you don't have enough radiotherapy and clinical oncologists. The level of care provided is not adequate. That means specialized care or advanced care to be given by each specialist is not adequate, is suboptimal. That means the quality of care is also suboptimal. The patient is not getting best. Then the facilities are not enough. For example, how many tertiary healthcare institution have a functional radiotherapy machine. Access to the care is not also adequate. Now, how many primary healthcare facilities or secondary healthcare, that is general hospitals and co, can provide oncology care? Most of the patients have poor access to those healthcare, and they have to travel to the distance for referral. And even in the referral, there are a lot of distance. The manpower gap is just not adequate. How about affordability of care? It's one of the major problems with oncology care. Sometimes it is called financial toxicity. That you have all the things you can have, but you cannot afford the care. So that means we are back to square one. How about acceptability? Sometimes we have, especially in our Nigerian settings, we may perceive that oncology or cancers are not diseases that should be managed in the hospital. You come to the hospital, you are trying to make it worse. Yes, even if you have some people or patients that accept it, how about tolerability? Once patients start receiving some session of chemotherapy or radiotherapy, after suffering the side effects without proper counseling or education or adverse event management, they may have to drop out from the care distance. So that patient dropout now will worsen the whole situation. So from this little cycle, from this little slide, we can see that you have multidimensional care gaps in oncology. Now let us see. This gap, for example, in oncology workforce, as American Society for Clinical Oncology, ASCO, have this beautiful chart as of 2015 that shows a projected demand in oncology service, demand for oncology service versus the services that are provided, that is the supply. You have a very low supply compared to the high demand. So that means the patient that need that comprehensive oncology care are much more in number. Each patient need a lot. But for each patient, not all the care that he or she deserves is being provided. And there are not enough oncologists to cater for the services that those this thing demanded. So now this led the oncology world to go back to the drawing board. How do we do? What do we do? How do we close the care gaps? And among those things, thinking within the box, not outside the box this time around. We have a lot of practitioners, we have nurses, we have this. So some practitioners were classified among the advanced practitioners, like clinical pharmacists. What will they do? They consolidate on the efforts of the physicians. They advance their practices. They take some more responsibilities so that the care gap can be closed in oncology. Now let us see. Closing the cancer care gap through clinical pharmacists. Since we see that we have a lot of gaps. Now, this slide is just showing the gap in terms of number, okay? In terms of the number of patients that visited and those that were actually cared for. But it's not showing the quality, the types of caregiving, and many other things. Now, let us look at the pharmacist perspective. If you look at it, before you just have pharmacist and patient. That is the old paradigm of care. The new paradigm is that you have the primary healthcare providers, oncology nurses, oncologists, caregivers, social workers, and I just cycled the pharmacists so that, because that is whom we are, that is where we see the role of a clinical pharmacist. You may recall that a pharmacist collects, assess, collect patient data, assess the data, develop a plan, implement the plan, and follow up and set up monitoring parameters to evaluate outcomes. If a pharmacist do this, then the pharmacist has provided pharmaceutical care. So let's also recall that we have this pharmaceutical care to be provided. And some of the responsibilities pharmacists have in oncology care, there are many, but let's look at these 4 cardinal responsibilities we go into specifics. Utilization of drugs or managing drug utilization, drug therapy management, okay, channel or formulary management, like drug therapeutic committee to discuss which formulary to set, which drugs to keep, and what are their effectiveness, what do you have that is new, and all those things. Then you have drug cost management. Okay, can you minimize unnecessary cost? Yes, pharmacists do that. Pharmacists also advocate for more fund so that they can cater for patients that may not have enough or that have financial barrier to to their own treatment. Yes. So now from those responsibilities, let me just share this survey that was conducted that shows that, okay, what do pharmacists, clinical pharmacists do? And most clinical pharmacists, more than 50% of them, participate in direct patient care. Direct patient care means a lot. Adverse event management, managing the cost, okay, managing this thing, managing the formulary and other things. You have the patient or medication dispensing, you have follow-up, you have investigational services, you have supervision, okay, and these are management aspect. You have the academia, that is training, mentoring, okay, oncologists at academia. You also have some role in the industry. So that is the list in order of their frequency. Okay, even in oncology, you have different distinct roles. Different of them. Let's say that in oncology that we have 10 pharmacists. 10 of those pharmacists may have different role, different job description. And that job description, I call it subspecialty. Let us briefly look at this. You have practice management oncology pharmacists. These are managers. Let's say that you have a director of pharmaceutical services that is an oncology specialist that manage the hospital, the medication supplies, okay? Probably the person doesn't go to the hospital, but manage the insurance companies, manage supply chain of oncology medications, collaborate with social workers to look at patients that may not be able to afford, okay? Do a lot of managerial aspects. I believe we all understand the pharmacy management point of view. So in oncology, you have those that basically do that. Now, most of our hospitals, you see that most pharmacists in oncology actually do this management. They participate in meetings, they do this, they do that. So most of them are practice management oncology pharmacists. You have also infusion center pharmacists. I think we popularly know it as oncology reconstitution. Okay, you have people that's okay. You have a kind of lab in oncology units with safety equipment and all the personal protective equipment so that this person will reconstitute the infusions or the parenterals that will be given to patient at an appropriate dose, appropriate strength, bear in mind the patient's demographic and clinical characteristics. Yes, had it been, assuming that is a mistake in the dosage or the concentration, looking at the patient comorbidity and other things, these reconstitution pharmacists will raise an alarm so that that thing can be corrected. We also have inpatient clinical oncology. Okay, this one is not directly in the reconstitution lab or center, but also involved in direct patient care so that they look at what drug is the patient taking, what are the things to monitor in this patient, that those are the outcomes to monitor. In other words, providing inpatient pharmaceutical care. Then you have specialty oncology pharmacists. These ones handle a specialty or some specialty cases. Let us say that you have an oncology patient that has end-stage renal disease. So you have somebody that understands end-stage renal disease and also the oncology, so that these two comorbidities can be managed. Or you have a geriatric patient or a pediatric. So in that case, specialty, you can have somebody that is better in handling pediatric cases of oncology. Then you have the academic oncology. Yes, even those that are practicing in the oncology center or in the hospital, if they are involved in training pharmacy students, providing residency or training residents, in participating in research and also publication, doing some clinical trials. These are some academic activities that go hand in hand with the oncology practice. There are more of them, but from here, we look at it that, okay, now you have different practice areas. That means if each of these can be addressed, if you have clinical pharmacists that concentrate in each of these 5 areas and even more, then we are already on our road to closing the oncology care gap. Okay, now at almost, I think, the 3rd or 4th specific learning objective in this presentation. That is looking at the impact of clinical pharmacists. Yes, in the objective, we say potential impact of clinical pharmacists in closing cancer care gap in Nigeria. But here now, in the coming slides, we will look at each impact and maybe one research finding that supports that impact. And that shows that that is a potential impact in Nigeria. Of course, some impact must have been met directly or indirectly, but that shows that we can also maximize on that to create more impact to Nigerian cancer patients. Now, in this chart, this summarizes the impact: safety, access to care, participating in testing, cost management, educate patient and also other caregivers, provide support, okay, improve the patient outcome, manage or optimize medication adherence. Okay, all these ones are some of the impact in summary. Specifically, let us look at a few of them. Clinical oncology pharmacists decrease oncologist workload. You may recall that we say from that ASCO projection of oncology workforce demand versus supply, when there was a gross under supply of the oncology care demands. Now, based on that, the board certified oncology pharmacists now, it shows that board certified oncology pharmacists now could provide patient care for 2.6 to 3 million people, okay, as against the projected 9.4 to 15 million. Yes, unfortunately, these projections are US based. We don't have that data for Nigeria, but if you look at it, if you have a data like this, even though it is US based, it is also proportionate. In fact, you may even see more of cancer patients in Nigeria that were under or more mismanaged. So you have more cancer patients and less oncology specialists in Nigeria. So you could say that the even data could even be worse in our onset, looking at our own. Either way, it is good. It shows a lot of lead that need more practitioners in oncology. So now, oncology pharmacies decreases the oncology decrease oncologist workload, and that means they added to oncology workforce. And oncology pharmacists decrease workload by performing a lot of tasks ranging from providing immunization, resolving delays in issuance of insurance coverage, obtaining up-level medication, educating patients. Nearly 75% of new approvals in oncology who possess this thing. So you see that 75% of new drugs, 75% of new FDA-approved drugs are oncology drugs. That tells you how much oncology negatively impact the public health, and the fact that most of the new drugs are oncology drugs, and the fact that you need pharmacists to dedicate his life in understanding these drugs, their side effects, how they are used, so that they can educate patients and also other caregivers. Let us look at another impact: management of symptoms. Yes, many studies have demonstrated the impact of pharmacists in managing symptoms. In fact, some studies show that there is a study that shows that patients receiving intensified care from oncology pharmacists reported fewer overall medication adverse events. Look at the hazard ratio. Fewer adverse events related to oral oncology therapy. You have reduction in combined severe adverse events that include discontinuation of treatment, unscheduled hospitalization, and also death related to adverse events, okay, in patients receiving pharmaceutical care. Also, unscheduled hospitalizations were also reported to be low, that is 3% among patients that receive pharmaceutical care against those that receive that did not receive pharmaceutical care, which is 14%. That means about 11% reduction in unscheduled hospital admission. Treatment discontinuation was also proven to be low, which is 19% compared to 31% treatment discontinuation among oncology patients that did not receive pharmaceutical care. So this shows you that clinical pharmacy has a lot of impact in oncology care. Hence, clinical pharmacy has a lot to do in closing care gap in oncology. Now, another one is improved patient-reported outcome. I think we can skip this. By the time you have all these managing symptoms and a lot of things, automatically patient-reported outcome will be positive. And a lot of studies have also shown that. Then there is another thing that is collaborative practice agreements. A pharmacist participate in collaborative practice agreement, whereby pharmacists that participate in that, they assist in prescription refill, okay, prescription refill, patient management like interpreting, monitoring lab tests, developing therapeutic plan, educating patient. In other words, prescription role of pharmacists is increased in collaborative practice agreement. And that one, it has reduced, it has decreased the turnaround time to refill prescription to 7 minutes as against 2.3 days. That means to refill prescription for oncology, for cancer patient, it takes 2.3 days, but with the pharmacy, it's just 7 minutes. So as soon as there is need for refill, okay, they refill and the patient gets his medication and go. And this will improve treatment effectiveness, adherence, satisfaction, patient-reported outcomes. You can name a lot of them. Management of cost of care. So mostly, this aspect of clinical pharmacist practice is normally underreported or often undocumented. A review of chemotherapy orders by oncology-trained pharmacists for 10 weeks shows that there are 49.2 prescription orders that need modification. This modification now will lead to reduction in the total cost of care by $462,000 US. Another study also shows that pharmacists that evaluate polypharmacy in adults shows that, okay, for each prescription, okay, for each prescription, there are 3 medications that can be avoided, and the cost of those medications average $4,282 for the total healthcare expenditure. You know what, to estimate this, when you look at it, you look at how many medication for how many cycles, for how many years for that treatment. Interestingly, a lot of studies now that are conducted have demonstrated that my colleague recently performed a study in renal patient, and it shows a lot of potential cost saving due to the intervention of clinical pharmacists. Yes, clinical pharmacists also has impact in optimizing anti-cancer drug therapy. Okay, optimizing medication adherence. Yeah, optimizing medication adherence to anti-cancer therapy. Yes, a study shows that prior to pharmacist-led quality improvement initiative, that is before the intervention of pharmacists, there are 48% of cancer patients that discontinue treatment, that is oral anti-cancer drugs. But with the involvement of clinical pharmacists, no patient discontinue medication on their own. That means 100% adherence. So this shows you another impact that clinical pharmacists play in closing the oncology care gaps. Another impact potentially for Nigeria is that patient advocacy and access to medication. Yes, especially in Nigeria, some patients have this poor financial toxicity, simply financial barrier. They don't have money, they can't afford. So now a clinical pharmacist can look at the way of substitution or avoiding or some medication that are avoided, so that most patients that could abandon therapy now can now be able to access their therapy. Also, in terms of patient advocacy, is to advocate for more. Like when you know philanthropists, you are in oncology, you know some philanthropists that provide funding for the less privileged. So if you have a pharmacist there, he can advocate for some fund, get some medicines so that those that cannot afford, and they will be able to afford those services. Also, in terms of influencing legislation towards insurance and many contributory health care scheme, non-inclusion of cancer medication in NHIS list. That was the case before. That was the time that we had that NHIS does not cover oncology. I think now it does, maybe. Yes, I think it does now. So those are some of the advocacy. Yes, support informatic. Clinical pharmacies, popularly known as Drug Information Center. It's only a pharmacy that can manage DICs, that is Drug Information Center, so that every new drug that was approved, now the pharmacists update the database for Drug Information Center, because his whole life is dedicated to drugs and not the disease, so that appropriate information can be given to patients and also to caregivers. Education, educating the patient and also health care providers. Educating patient on adverse events, on treatment, prognosis, expectations, hospital visit, and all those things. If you have a pharmacy that has more time for the patient, then the patient will get better due to those education that is provided. Then oncology pharmacists also in collaboration play important role in educating physicians, advanced practitioners, nurses, students, residents, and other people based on the medication, and that improve or that helps in closing the oncology care gap. Mitigating drug-drug interaction, of course. What else? Pharmacies. Because you have a lot of drugs that you use in oncology, antiemetic, analgesic, okay, and many drugs like that of different DDIs related debt. So pharmacies has a key role in managing drug-drug interactions. Then preventing medication error and enhance medication safety. I think we don't need to overemphasize this. Manage drug shortages through maintaining appropriate supply chain of medication. Okay, serve this thing in pharmacy and therapeutic committee to manage formularies. Okay, I think we also highlighted that. So you have a lot of roles a pharmacist can play in closing the oncology care gap. Different roles and different potential impact that we have looked at. But are all these things realistic? What do we have in practice? Yes, a lot of these were practice. Pharmacists help in improving adherence to constitution in many hospitals, improving the oncology workforce, okay? A lot of things. Sometimes we practice without knowing the impact of what we are practicing. That is why we need to know some of these things, and that is why we need documentation of all the things we are doing so that it will show how much impact we're making, okay? So now, that means these are more of expectations. And yes, what are the reality? The reality is that we may not be able to meet all those expectations, especially in Nigeria for now, but a lot of those were done in practice. So this is the kind of wake-up call so that we can improve our listing. We can keep improving our practice so that we can be meeting our own expectation. Now, the final objective is to see a roadmap to closing the cancer care gap by clinical pharmacists in Nigeria healthcare atmosphere. This is an open discussion. Nobody can just say that this is the kind of roadmap. It needs a lot of expert opinion and discussions. But personally, the things that we know about Nigerian healthcare practitioner practice, we often think some of these our role may not really be needed, or we may not do it. And because of multiple reasons, for another discussion another day. Now, I have this simple roadmap as a basis for our discussion so that we can build on that. How about a clinical pharmacist practicing in oncology setting, building interest? I'm interested in providing some impact in oncology, or I'm interested in oncology, or rather people are suffering in oncology due to lack of access to medication or lack of affordability. I'm interested in practicing. So when you have somebody that is interested, then it is easy to get the best out of you. Then when you are interested, you have to get a mentor, one way or the other. A pharmacist, a physician, a nurse that is well experienced, a pharmacist from another institution, name it. Get a mentor and build your capacity. You can't give what you don't have. So you have to build your capacity so that your professional competence can also be integrated into it so that the patient can get the best out of you. They set simple goals. Mostly, we don't like doing new things in the practice because we just believe you need to make the whole thing perfect. Like all this impact that we mentioned, who can say that he wants to achieve all this impact within a year? Or these are the things I want to see. If you set that goal, hello, I'm back. Can someone hear me?
Yes, we can hear you, sir.
Okay, I had network issue, but okay. So let me share my screen again. We're almost there. How many minutes did I have left from 30 minutes? Anyway, we're going to conclusion very soon, so it doesn't really matter. Okay. So we're talking about roadmap for closing oncology care gaps in Nigeria. And we are talking about now build interest, get a mentor, and build capacity. Okay? Then set simple goals. You don't have to make your goals complex. For example, I'm alone in my center, oncology center, and my goal is simple. From now onward, I don't want out of stock. Every patient should get the medication. That goal can easily be achieved as long as this, then that goal can easily be achieved, then you have set a simple goal. Or from now onward, I want to start tracking all the medication given to patients to avoid simple interactions. Or from now onward, I want to make sure that patients that are discharged have some of their discharge medication, because maybe I realize that a particular cytotoxic can cause anemia, and most patients were not discharged with even simple hematinics. So if you have that goal, achieve it, then move to another goal. Take the first step. Mostly we are afraid to start something, but taking the first step means you can take another step and another and continuously. So in my center, let's say that we want to start participating in oncology care round or meeting or multidisciplinary meeting. The first step is we look at it. Let us look at who is the head of the unit or the CMD. We establish some understanding, set our clean goals, then we go on. Then, if you can take the first step, as you are doing, get a mentor. Your mentor will ensure that you keep updating your knowledge, you keep learning so that you have something to give. And in case you are not around, the good work you start may not go with you. Somebody can continue. Be a team player. Mostly we have problem participating or working in teams. So yes, this is attributed to our maybe manpower, the practice, the way we have been. So we can't just get there overnight, but you have to start somewhere. So if you like, or you can play, if you can work in a team, then you know how to set your objective and achieve it, how to talk to a co-colleague from another discipline so that you understand each other, so that your objective can be achieved, so that your impact on patients can also be felt. So now, this is just like a template, which I believe once we are done, we will have a lot of contribution on how do we set a roadmap, how do we close care gap. We have multidimensional gaps in oncology care, but clinical pharmacists can do a lot in closing those gaps. So we can conclude by saying that cancer needs a comprehensive, multidisciplinary, and collaborative care for optimal patient benefit. And clinical pharmacists have proven to be indispensable in providing direct patient care to cancer patients, closing the care gaps, and optimizing cancer patient therapeutic benefits. In Nigeria, a simple roadmap for maximizing the contribution of clinical pharmacists in cancer care can revolutionize cancer care by minimizing cancer care gap, improve patient therapeutic outcomes. As always, I thank CPAN for giving me this opportunity, my specialty group, Clinical Oncology Pharmacy, Dr. Rita, Dr. Leila, and other people's members of the education team. I thank you for all the support that you've been giving us. I always remember my mentors, those who made me the person I am today. In this forum, I can see Professor Maxwell Ibe, or whatever I said right, he contributed to it, and whatever I say wrong is because I was a bad listener. And many of my mentors from teaching hospitals, some consultants, and all those people that we work together with, my professional colleagues, Dr. Isa, and many people that also make sure that I do the right thing at the right time, and my family for at least supporting me to contribute what I can to pharmacy or clinical pharmacy in Nigeria. There are a lot of references, but I just mentioned a few here so that we can follow some and go back. As we always say in cancer, early detection saves lives. So whatever that is to be done, it will be better known if we have early detection of that cancer. Late detection also costs life. Thank you so much for your time. Over to you, moderator.
Yeah, thank you very much, Dr. Aminu, for this very well detailed, very concise presentation tonight. Indeed, I must say personally that my knowledge bank is full today. Your information is quite precise and comprehensive, and the time was well managed. We sincerely thank you very much. Now, just in brief summary, you educated us on some of the major gaps that we have in cancer care, which include workforce. We can actually attest to that in Nigeria with the current brain drain that we have, which can be attributed to economic instability we have in the country. And that's why we have to brace ourselves up tonight, that even few of us that are left, we can actually make significant impact in oncology practice in Nigeria. Also, you mentioned the level of care that people access. Yes, so many persons do not have the right care that they need due to financial hardship, cultural barriers, and different barriers we have at the moment. We also mentioned, yes, accessibility. We have to look at some people in the rural communities don't have access to some of the big tertiary institutions that offer this specialized care. They have to be reached out to. And we as clinical pharmacists have a lot to do with regards to that. You mentioned affordability of care. Yes, many oncology cancer patients do not have means to actually procure their medications. Actually, the federal government is doing a lot to actually find ways of subsidizing this medication. I know of the Cancer Trust Fund that has been established in Nigeria, but the truth of the matter is the level of corruption we are experiencing in the country has not really made people access that fund. And so many cancer patients die in waiting, accessing those funds. We also mentioned access to comprehensive care. Now, the truth is, the demand of workforce in Nigeria is actually very high, but the supply too is low. As I mentioned, the brain drain can be a factor to that. Thank you very much. You also bring to our knowledge or reminded us of the pharmacist clinical care processes. Yes, as clinical pharmacists, and our key roles and responsibility, which is not limited to the following: utilization of medication, ensuring proper drug and therapy management, formulary management, and ensuring that our patients get the maximum care that they need. We went ahead to actually classify the various oncology pharmacy specialization or areas that we can look into, which includes pharmacy management, infusion management, inpatient clinical care, now specialization areas, and academic oncology. Now, coming to the core area of our topic of our discussion today, what can we do? What can be our impact as clinical pharmacists in closing this cancer care gap? We made mention of, yes, improved patient outcome, which is our primary or core responsibility as clinical pharmacists. We are not clinical pharmacists if we don't make significant impact in the life of our patients as it is. You mentioned collaborative practice. Yes, we do not act in isolation as clinical pharmacists. We work with other healthcare providers as a team, and that way we can be able to make our significant impact and get the respect we are desiring in the society. We also made mention of management of cost of care. Yeah, that's where we can actually make significant impact in closing the cancer care gap. Actually, there are many schemes by the federal government as it is, in collaboration with other pharmaceutical companies to actually subsidize this medication and make it as affordable as possible for them. Because so many patients not progressing with their treatment, they actually abscond because they cannot afford the cost of their treatment. Now, yes, adherence, mutual agreement between the patient. We clinical pharmacists actually play a significant role in that. Also, you went ahead and mentioned, yes, we are really the drug experts in giving information. And giving information, it has to be correct and adequate as it is. Now, patient education and patient care is also paramount in closing the cancer care gap. This is just like a summary of what you actually told us tonight. I sincerely appreciate you. Now is time for comment, contributions. Yes, the speaker of tonight has really made his research, but we may want to give one or two contributions or questions. Now is the moment. I actually want to throw the floor open so that anybody that has any comment or contribution can make. Thank you very much. You can make your comment even in the chat box, or you could raise your hand. Okay, I can see Dr. Felicia Williams. Ma, your hand is raised. Please unmute and make your contribution, ma.
Good evening, everyone. We appreciate Dr. Aminu Ahmed for that beautiful presentation. One area that is a major barrier to closing the care gap has to do with concomitant use of herbal products, traditional medicines, either concomitant use or even some patients prefer that to oncology medicines. Can you please help us throw more light on what we can do as clinical pharmacists to closing the care gap in that area? Thank you.
Dr. Aminu, sir.
Yeah. Okay.
I hope the question is clear.
Yes, I've gotten it. I thought maybe someone want to ask so that I can, but let me just go on. If somebody raises his hand, then we can. Okay. Concomitant use of herbal product. In fact, it's a big barrier because the perception is normally not a good one. Because mostly I know here up north, our people believe that cancer is not a disease that should be managed in the hospital. So they use herbal products. Even if the condition keeps getting worse, they won't come to the hospital until when the condition is at its own end stage. So now, if you have a clinical pharmacist that know that herbal products can interact or interfere with that, then that patient education can help in mitigating that problem, so that do one at a time. If you have the patient, if you are lucky the patient came to the hospital early, tell the patient to suspend every herbal product until you are done with this, so that you avoid drug-drug interaction. Any public health aspect of or campaign about cancer can address that. Can be managed in hospital and can be managed in hospital, the issue of early detection and management. Then the issue is we also have effective herbal products in cancer, but how can we substantiate or confirm their effectiveness or otherwise? then we have to go back to our research beyond the DEX research that we do. I used to have this passion that, okay, maybe in future, why can't we come together, look at the herbal products that were thought to be very good to have anti-cancer drugs, whether in vivo or in vitro. You know, mostly what they do, you look at cell lines, culture them, then test them, look at the toxicity and see whether they have anti-cancer potential or not. But in future, if there are some of those that I'm sure are very good, we can take it up, look at how we can minimize the bottleneck in the clinical trial protocol, then test them and be able to get some of those that are also that actually have more potential. So we're not throwing the herbal products away. We need the herbal product to develop new drugs, because up to now, we have a lot of barrier. Effectiveness of the medication is also big barriers. You can look at a cancer treatment, cytotoxic, they are very okay. Now I can tell you that if it's about identifying cancer, give anti-cancer drug that will eliminate that cancer or radiotherapy is no longer a problem. But how about reoccurrence, metastasis, and all those things? How do we address them? These are problems that still cannot be listed. We did a research courtesy of my professor here. We look at how well does this cytotoxic affect or improve survival. We look at it, all of them improve survival almost at equal rate, but not all of them are equal. Some are better in patient-reported outcomes, so are better in this and that, but really no survival. No matter what, the patient will eventually have reoccurrence, metastasis, and eventually end-stage cancer case and also die. So this is a very big barrier that is global, not just Nigeria in nature. So to summarize this point, you educate through public health campaign, you educate through direct patient care, you take one at a time, either herbal, if the patient comes, suspend herbal so that you use the orthodox. Then we intensify our research on those herbal products beyond the DEX. Like we always say, from desktop to bedside. The ones to champion this bedside, the best are clinical pharmacists, either in hospital, clinical pharmacists in hospital and academia in collaboration with other healthcare workers, so that we identify some of those herbals that have good potential. Let us see whether we may be lucky to identify some promising anti-cancer that can also do well in terms of preventing or delaying metastasis and also the occurrence of the disease. I hope I have not done another lecture on this herbal thing. So if there is another comment or question. Okay, Dr. Rita, are you there? So that we can progress. Hello, can anybody hear me, Dr. Isa?
Yes, I can hear you.
Okay, very good. We have spent more than 1 hour and gradually we'll be reducing in numbers. So if there is, my method is, if there is no more comment, it's good we close the meeting early so that people will not get too much bored. That is why I finish the lecture early, please.
Yeah, thank you very much, Dr. Aminu, for that good answer to the question of Dr. Felicia. It was very, very elaborate. Yeah, collaboration is key, and research too cannot be ignored. We sincerely thank everyone that have deemed it fit to join the CPAN presentation with the Clinical Oncology Pharmacists of Nigeria clinical meeting of today. We thank our guest speaker. As I said, I apologize on behalf of our moderator today, in person of Pharmacist Laila. I think she's having a network challenge. We sincerely apologize for that, and we hope next time we improve on our lapses that it's rare. Thank you everyone that joined us for today. I don't know if any of the CPAN and national executive have one or two contributions or comments to make.
I think they can take the floor. We started from.
Yeah. Hello.
Dr. Lulawal is here, Dr. Timifri is here. They can make comment on our behalf. Dr. Timi, are you there?
Dr. Timi?
Yeah, I'm here. Good evening, everyone. I want to thank you so much. It was a wonderful presentation. We want to appreciate the oncology specialty group for this wonderful presentation. And we are also, just like you have also mentioned, the moderator has mentioned from the beginning, the desk officer one, the plans of this specialty group. And to make you know that oncology specialty group always have representation every month, once every month, and they will try to keep it up. Thank you so much, Ma. It was a wonderful presentation. Thank you.
Moderator, I think she has lost her connection. I cannot see her again.
Okay.
Dr. Timi, you can conclude, please.
Yeah,
Close the
okay, all right. So let's have the closing. We've had the closing formalities. Thank you so much. So just let's have the closing prayer. I don't know if we had the Christian who did the opening prayer. So can we have Dr. Issa, please, can you post round up? We'll call it today. Thank you.
Okay, in the name of God Almighty, the most beneficent, the most merciful, we thank you, God, for bringing us to the end of yet another impactful program of CPAN. We pray that as we go to bed tonight, for those in Nigeria and other places, you give us strength to replenish our energy and wake up stronger and get ready for the works of life. We pray for this and many other. Thank you, God, and good night, everyone.
Good night.
Yeah, good night, everyone. Good night.